Before we really get started, I want a show of hands. How many of you go down the shore in the summer for a weekend here or there? Okay, and how about the rest of you? Do you guys go to the pool? Okay, so more beach than pool. Those are obvious sources of sun exposure that we're all aware of. We know that when we go to the beach or the pool that we're going to be in the sun, and hopefully we remember to wear sunscreen. But there's other sources of sun exposure that we sometimes forget to think about before we do them. Who here does lawn work as a chore or gardening as a hobby? It's most of you. What about outdoor activities, sports of any kind, walking? Probably most of you do some of it. Driving, I'm sure every single one of you drives pretty much every day, going to and from work, running errands. When we're driving, the ultraviolet light, UVA, penetrates our windows, so that exposure actually counts, even though you might not get a sunburn from it. So what I want you to think about when we're going through the talk is how are you exposed, and then what I'm hoping you'll learn from this is how you can protect yourself day to day, as well as during the times when we know we're going to be out. So we're going to start by discussing sunlight, what it is and what its effects are. Then we're going to move into the precancerous skin lesions and the skin cancers that we can see. My goal there is to educate you on what these things can look like so that hopefully you can detect these things early in yourself if you ever get it, or detect it in your family members if they're getting it. Then we're going to discuss the risk factors, and we'll go through those a bit. Finally, we're going to go through recommendations for day-to-day as well as for purposeful exposure to sun. So starting with sunlight. Sunlight is an electromagnetic spectrum of varying wavelengths. We have included in that the infrared light that we can feel, the visible light that we can see, and then ultraviolet light, which is the light that can penetrate our skin and affect our skin through our lifetime. Looking at ultraviolet light, it's divided into UVA, UVB, and UVC, but it's a continuum of wavelengths with gradually changing properties along that spectrum. So the difference between UVA and UVB is not stark. It depends on what wavelength we're talking about. Now looking at that spectrum, UVC doesn't really affect us. That is mainly blocked by the ozone layer. UVB is the chief cause of sunburns. This is some of the shorter wavelength ultraviolet light. When it comes down through the ozone does block some of it, but not all of it. As it comes through and hits our skin, it's mainly absorbed by the epidermis, which is the topmost layer of the skin. That's the layer that's constantly growing and shedding and renewing itself, and that's where UVB has its damage. It is the chief cause of sunburns, so when you do go out and you get burned, you can blame the UVB. UVA doesn't cause as much burning, it doesn't cause as much acute damage, but it does have a very significant role in aging. UVA goes deeper into our skin when we're exposed to it because it has a longer wavelength. So it affects the connective tissue and can lead to the signs of aging, which we'll review in a moment. Now, looking at UVA, some of the shorter wavelength UVA is thought to contribute to skin cancer the way UVB does. So both types are important. Even though the B gives us the obvious burning, the A gives us the aging, both likely contribute to skin cancer. Now let's talk about the effects of sun exposure. First, the positive effects. There are positive effects from sun exposure. It's not all bad. When we go out, we get a sense of well-being and we feel really healthy and happy, and it's warm and it's really pleasant. They've actually done studies looking at tanning salon use, and they found that tanning releases endorphins, which is the feel-good chemical, and it may even be addictive because of that endorphin release, but that's why we all feel good and happy when we're in the sun. Now another thing that we like is the tanned skin that we get from being in the sun, and that's cultural more than anything else. It's been, in the last several decades, popular to have that healthy tan, that vacation look, but healthy tan is an oxymoron. It's not healthy. Now vitamin D synthesis is an interesting positive effect of sun exposure, and you may have heard about this on the news and in the press because there's been a lot of controversy about vitamin D in the last few years. Vitamin D is a very important vitamin for us. It affects our bony health and our general health. In general, the way we make vitamin D is when the sunlight hits our skin, it generates active synthesis of vitamin D that then goes into our bodies. We also get it, though, from our diet, and we can get it from supplementation. Now, one of the things that's being talked about in the press is that we don't get enough vitamin D. Our levels are too low, so we should all go out into the sun and get our vitamin D. It's not that cut and dry. It's true that sun gives you vitamin D, but the healthier way to get it is through diet and supplementation. And one study that was interesting was they showed that a fair-skinned individual in June at around noontime in Boston generated the maximum amount of vitamin D that they could within 5 minutes. So you don't need that much exposure to get significant vitamin D. If you're very concerned about vitamin D, you should really look into your diet and supplements. So moving on to the negative effects. Sunburns, aging, precancers, and skin cancers. They're all associated with sun exposure, and we're going to go through those now. Now, how many of you have experienced this? Pretty much most of you, right? And I'm sure some of the guys have had this occur where they forget their sunscreen and bake everywhere but their bathing trunks. This is an unpleasant experience. I myself have experienced it many times when I was a kid. Not fun to go through. It's acute damage by UVB, but it does have long-lasting effects as well. The more sunburns you have, the higher the risk for skin cancer. And in fact, if you've had more than 3 blistering sunburns, especially in youth, your skin cancer risk goes way up. Now here's an interesting picture. This is a woman, obviously she was wearing underwear. She was actually in a light booth, kind of like a tanning salon, and was overdosed, hence the very severe burn. I like this picture because it's so dramatic and it shows how severe a burn can be relative to normal skin. But what I also like is if you look along the seam of the underwear, you see how there's some red? UVA can penetrate clothing, and you might not burn through most of your clothing, but you are getting some cumulative damage when you're out. So you do have to think about that when you're doing lawn work, that sort of thing. If you're wearing a loose weave white t-shirt, a lot of the sun is penetrating that. So it's something to consider, and we'll talk about sun protective clothing later. Now, really bad sunburns can lead to blistering, such as on this child on his lips, and that's extremely unpleasant and also very damaging. Now, looking at aging. Aging of the skin, at least 80% of it is from our incidental exposure as well as our purposeful exposure. And what I'm talking about when I say skin aging, we're talking about the things that happen that we don't like as we get older, the loss of volume with the sagging of the skin, the wrinkles that we get, especially the deeper ones, the discoloration, the leathery texture. Most of that is from sun exposure. Some of our aging, 20%, is from genetics and just destiny from living in gravity is how I would put it. But 80% is from the sun, so there's where we can make a difference if we want to decrease our evidence of aging of the skin. And that's important for looks, of course, but also very important for skin cancer. A key thing is that while the sunburns cause acute serious damage that can cause long-lasting effects, the daily exposure that we get when we're driving and the UVA is penetrating through that window, when we're sitting in the office and the sun's coming through the window, we're doing a little lawn work, we're walking around the neighborhood a little bit, you might not burn, but you are getting cumulative ultraviolet damage that over the years has effects. Now this is a great picture. I put this picture in because it just demonstrates how much incidental exposure can affect the skin. This is an office worker who worked at the same place for 15 years, and she sat at a desk with a window to the left. And she wasn't really a weekend sun worshiper or anything like that. So her damage was just from the window. And you see on her right side of her face, the side that didn't get sunlight, her skin looks quite good. It's pretty nice. But her left side has that leathery texture, the deep wrinkles, a little bit more sagging, definitely a stark difference. If nothing else convinces you that incidental light exposure has an effect on our skin, this picture really should. I think it's a great picture. Now, let's move on to precancerous skin lesions. The main thing I'm talking about here is something called actinic keratosis. Actinic keratosis is a precancerous skin lesion that can become squamous cell carcinoma, one of the non-melanoma skin cancers that we'll be discussing. It's very common. We see this all the time. It affects at least 10 million Americans. The causes are mainly cumulative sun exposure as well as genetics. And what we're talking about with genetics, we're talking about being fair-skinned, having a family history of skin cancer. And we'll go into genetics a little bit more later. Now, studies have shown that use of sunscreen regularly can decrease the incidence of actinic keratosis, hopefully prevent you from ever getting them, but if you are someone who gets them, that day-to-day sunscreen can actually reduce how many you make. Now, here's an example of actinic keratosis. This is on the back of a woman's hands, a very common site. We see these most commonly in exposed sites, including the head and neck, the ears, the lips, the V of the chest in women, the backs of the hands and the forearms. So those are the places that we get damage most of the time, just driving around. It's not necessarily where we got our sunburns. Now, if you look at these lesions, on her right hand we see some red splotchy stuff. Those are early precancers. Sometimes they're just a little bit red and a little bit rough to the touch. You might not see any obvious dryness. Looking at her left hand, she has some crusted lesions where it's thicker. And This is fairly typical for a presentation of actinic keratosis, but we can see them present without any redness. They can be flesh-toned. In darker-skinned individuals, they can have color and have some brownness to them. The main thing is that they feel like sandpaper when you rub your finger on them, so they're more palpable than anything else. You want to treat these at this point because the treatment is pretty benign. We freeze them off with liquid nitrogen and hopefully reduce your risk of developing cancer at that site. If not treated, a significant number probably do become squamous cell eventually, although some of them do go away. Sometimes people will say they come and go. Now here's the same condition but on the lip. It's called actinic cheilitis. Lips get a lot of exposure day to day, especially if you don't tend to wear lip balm or anything with sunscreen. And some people will develop precancerous changes on the lower lip with the same sort of crusting and redness. It's kind of like chapped lips but more persistent and rougher to the feel. And this is very important because if actinic cheilitis becomes skin cancer, squamous cell carcinoma of the lip has a higher risk than squamous cell carcinoma of the skin of spreading internally. So if you develop this, you definitely want to be treated and followed closely. Now moving on to skin cancer, we're going to start by discussing some of the statistics. 1/3 of all cancers of any kind diagnosed in the United States every year are skin cancers. So we're talking lung cancer, all those cancers, 1/3 are skin cancers. Over 1 million new cases will develop this year in the United States. And in a lifetime, 1 in 5 Americans will tend to develop skin cancer of some kind. Now looking at what are the skin cancers, we're going to talk about basal cell, squamous cell, and melanoma. Basal cell carcinoma and squamous cell carcinoma are the non-melanoma skin cancers that usually don't spread inside the body but can. Melanoma is the big one that we're all scared of. That's the one that definitely has a significant risk of spreading and causing death. What's interesting is look at the stats here. They're projecting about 11,000 people will die from skin cancer this year in our country. 8,000 of those are from melanoma, but 3,000 are from the other skin cancers. So while the other skin cancers are a lot less aggressive and less serious in terms of life or death, they can progress to become very significant and spread internally. So you do want to catch those early and treat them because they're very curable. Now melanoma has become a hot topic because the incidence has been increasing dramatically over the last several decades. One report said that there was a 690% increase in incidence from 1950 to 2001. In general, we're seeing about a 4 to 6% increase yearly, and it continues. We're not really sure why this is. Some of it is probably the sun exposure. Tanning salons have become very popular in our younger people these days, so I think all of that is going to continue to make this epidemic worse. Now, let's talk about basal cell carcinoma. This is the most common skin cancer. We see this very commonly all the time, especially on fair-skinned individuals, but it can occur in anybody. When it grows, it tends to be locally invasive. And what that means is pops up on your nose, gradually grows usually, and causes localized tissue damage. If caught early, there's not going to be much damage. You just scrape the thing off, treat it, and you got a little scar. But if it's allowed to progress, it will continue to grow outward and inward, and as it grows, it destroys more skin, can penetrate into the cartilage, and eventually into the bone. So it can cause a lot of disfigurement, especially if caught late. Rare cases grow fast. Basal cells usually slow growing. Now, this rarely metastasizes. It's almost unheard of to metastasize. The main damage is that localized damage, but if neglected for a long time, you can see death resulting from this. Now, studies are looking into what kind of exposure contributes to someone developing basal cell. And so far, it looks like it's more related to that intermittent, intense sun exposure that we got in our youth, the sunburns that we probably all got. You also got to think about weekend warrior lifestyle, though. That's what a lot of people do these days. We work in an office all day, all week. The weekend comes and we're at the beach, we're down the shore, or we're out gardening for 3 hours. All that damage likely increases the risk of basal cell as well. Now I'm going to take you through some pictures. Some of them are a little bit gross based on what the people at the last talk said, so I apologize in advance. I'm going to just try to walk you through some of the presentations of basal cell so you can recognize it. We call this type of basal cell a rodent ulcer because it looks like a rat bite. It's actually in the literature, that's what we call it. If you look at this lesion on the cheek, you see an indentation with some bleeding and red color, and then the edge of it, what makes it not just a wound, is that rolled, elevated border. And if you look at it, it's elevated, it's rolled. If you press it, it'd be firm, and it has a shininess to it. We call it almost a pearly look. So this is a fairly classic type of basal cell. Here's another example where they didn't actually have a wound, but you can see that rolled border and slate shininess. There's actually 2 lesions present here. Now here's the more common presentation. We call this the classic pearly papule. Papule is our lingo for a little bump. Pearly is because it has that translucence to it, that shininess, and that's often a clue that something is a basal cell. In this case, you can also see that it's red. Sometimes they are very red, other times they're flesh-toned. If you look closely, you can also see little broken blood vessels going across the bump, and that's a common finding in basal cell. We call that telangiectasia. In this person, this is the back of the ear near the glasses. There's a lot of broken blood vessels in the area, and you can see that. That's just evidence of damage. But if you see them going across the bump, it's often a sign. And what's interesting with this case, it's the back of the ear. How many of you guys think of that as a place where you get sun exposure? You do over the years. And so you got to consider even hidden places as sources of skin cancer, even though it's not so common. Now here is a similar pearly papule, not as translucent. Just kind of looks like a bump that won't go away, a pimple that won't go away. This is also a common presentation. This is on the bridge of the nose. Now here's one that's also a bump, a little bit shiny, but it has more of a purple-gray color. This is a pigmented basal cell carcinoma. In patients with more skin tone, not as Irish-looking as me, more olive-skinned or even African-American, we will see development of pigment within the basal cell. It can be a grayish color, it can be speckled, or the whole thing can kind of have a colored hue to it. So sometimes we'll be concerned that this could be a melanoma, and then it turns out to be pigmented basal cell, which is definitely a better thing to get. Here's an example of a lesion on the earlobe. Now this one just kind of looks like a cyst or a bump that just won't heal. The clue here is the fact that it's kind of multilocular is how we call it. It's got a lot of different bumps to it. It's got a little crusting in the middle, probably has oozed. Now those were fairly obvious that something was going on there. But basal cell can be subtle, and in fact we like to find it when it's subtle because that usually means it's early and hopefully has caused less tissue damage. In this case, can you see the basal cell? Can anybody see it? It's right below the nostril, kind of right in here. It looks a lot like a pimple. If this person were a little bit younger and it was only there for a week, I would think this was a pimple. They're older, so that's one clue. And then the history is the clue. This is probably a lesion that's been there for more than a month. If you ever have a pimple-like bump that just won't go away for more than 4 to 6 weeks, that's when you really got to start thinking about the possibility that it's not a pimple. It may well turn out to be nothing, but it could turn out to be a basal cell. Now here the other clues are the redness and slight shine to it. This is a very subtle case, a little bit blurry, but you can kind of see the reddish patch. Not all basal cells are raised. There's something called superficial basal cell where it's just starting on the top of the skin, and that can be a shiny patch that has a little pink to it or a little gray to it. Often, if you look closely, you can see it having a wrinkled texture like cigarette paper. Here's another lesion. This is kind of a crossover between the pearly papule and the rodent ulcer. It's got that central indentation and the rolled edge with a little bit of shininess. And then you see a lot of the broken blood vessels in the area. You could see someone thinking that this was just a little pimple or a little mole that just was sticking around. Next picture I think might be gross. No, we're not on the gross ones yet. Okay. I want to warn you because some of them are kind of gross. This one's actually fine. This is an interesting case. This is an African-American woman, so it demonstrates you can see basal cell and skin of color. The basal cell is extremely subtle. It's on her left nasal tip near her nostril. It's just a little pink shiny area. This is actually called morpheaform basal cell, and you won't know it's morpheaform until you do the biopsy. Morpheaform means scar-like. Sometimes basal cell looks like a scar that you have no explanation for, and like no wound coming before it, and perhaps it grows a little bit and you notice it getting bigger. Morpheaform basal cell is very important to find early because this is a basal cell that tends to grow inward rather than outward, and so something small can actually turn out to have a lot of tissue destruction. Here's an example of a basal cell, ulcerated, shiny, probably has a history of bleeding. If you ever get a bump, a pimple-like bump that bleeds really easily, and I'm not talking about when you scratch it, I'm talking about you rub it with the washcloth and it bleeds and it's not going away, it may well be basal cell. Here's the gross one. This is an example of a very advanced lesion. This patient probably had this for a few years and neglected to get it treated. Sometimes we will see that in some of our elderly patients. With this, you can see obviously something's wrong. It's got that rolled border, it's got bleeding, and that's probably what brought the patient in. When we see these more advanced tumors, it's often been there, they've been ignoring it, and they come in when it starts to hurt and starts to bleed. A lesion like this has likely penetrated through the cartilage, and treatment for this would likely result in a significant disfigurement of the nose. So we never want to see it get to this point. With basal cell, it usually takes time to get this bad, although occasionally they do grow fast. Now, again, it's not only in whites. Here's a Hispanic individual with a lesion on the nose. They've got a lot of actually actinic keratosis in the background too. All those kind of splotchy areas are actinic keratosis, but the lesion on the nose is the basal cell. Here's an Asian individual with a basal cell on the nose, and this brings up the fact that it's not just in whites, but additionally, look at his face. Not a lot of damage there that you can see. He's quite young. Basal cell can occur early. We classically associate this with chronic sun damage, intermittent burns in 60s and 70s in terms of age, but we are definitely seeing it earlier and earlier. In the last decade or two, the average age is coming down. We're seeing a lot of it in the 30s and the 40s, especially in women. My youngest case so far is 21 years old, and in her particular case, she had nice dark skin, but she went to the tanning salons a lot, and she got a nice big basal cell right in the bowl of her ear, and didn't suspect it until it started bleeding, so pretty advanced when she came in. And that's becoming more common, unfortunately, and we think that's related to the lifestyle that we lead. Now, moving on to squamous cell carcinoma, this is the other non-melanoma skin cancer. Also one that tends to be locally invasive, so not a high risk of it spreading inside your body. It tends to be a little bit more aggressive than basal cell, can be faster growing. It seems mainly related to the accumulated lifetime sun exposure that we get, rather than those intense burns. We see a lot of squamous cell in outdoor workers, so landscapers, farmers, who've gotten a lot of exposure over the years. We'll see it develop there, but you also see it develop in the weekend warriors. Now, again, locally invasive and can cause extensive damage and disfigurement, but sometimes it does spread. Squamous cell spreads maybe less than 5% of the time, whereas basal cell is close to 0. The cases where it spreads are often neglected tumors, but it's also often in fast-growing tumors. Occasionally we will see these pop up overnight, they get big, and you know there's risk there. We also see increased risk of metastatic spread depending on the site where the squamous cell develops. On the lip has about a 30% risk of spreading inside the body. The ear, it's higher risk than skin, but not as high risk as lip. Additionally, certain patients have higher risk. Someone who makes a lot of squamous cells. Someone who is immunosuppressed, for example, on immunosuppression for transplants. We see squamous cell risk in transplant patients go up 40 to 250-fold. It's actually a huge thing that we're trying to educate people on. Kidney transplant patients seem to be at particular risk. It's probably related to the immunosuppression drugs that they're on. In general, if somebody has a immunosuppression from transplant or from chronic prednisone or anything like that for rheumatologic disease, they should be watched because they do have higher risk. Now, other things besides sun and immunosuppression increase the risk. Something interesting that I found is that cigarette smoking doubles your risk of developing squamous cell. Not really sure why that is, but it's another reason to give up smoking, of course. But it's also something for you to bear in mind if you are a smoker and you see something changing, you just have a little bit more risk. Other things that can increase your risk of squamous cell, arsenic exposure, which not a lot of us have an exposure to, ionizing radiation. If you've had radiation treatments for cancers of other kind, like breast cancer, throat cancer, your risk of squamous cell does go up and you should be watched. So we're going to move into the pictures now. This is an early squamous cell. It looks a lot like the picture of the actinic keratosis I showed you, where it's red, there's a little bit of scaling. The difference you can see here is that it's a little more elevated, more bumpy. This is actually a very early squamous cell, even though it's rather broad. It probably has not gone deep at all. It's good to catch it at this point. We see a lot of lesions coming in like this, but smaller. This is an obvious problem. This is a more severe tumor. Kind of reminds you a little of the basal cell that was neglected on the nose. This may have been there for a while, gradually growing, or this could have popped up over the course of months. I have seen ones like this pop up quickly. This is an invasive one. You can see the tumor itself. It's got the redness, the thickness, and then it's got this thick crust in the middle. And it's making a horn, actually. We call this a horn when it makes the crust so thick that it's just sticking out and it's a hard spot. It can be very tender. And squamous cells often will make these scaly crusts in these horns. Here's a similar lesion on the left cheek, also large, probably invasive, very significant. But you can see it can kind of look like basal cell a little bit, so the biopsy is the key, figuring out what it is. Here's one on the ear. Obvious something's there. When it started, perhaps the person thought it was a bug bite or a pimple that wouldn't go away. This is a more common presentation, actually. People are coming in earlier for these, which is good. People will come in with this exact presentation and think it's an ingrown hair that just won't heal or a bug bite that they can't stop picking at. The clue that it's something more than that is the thickness and the firmness of the bump, as well as the crust in the middle. And this is an invasive squamous cell, so it's got some thickness to it and will require surgery, but low risk overall of it spreading internally, whereas those other two that I showed you had a higher risk. Here's a similar lesion, just a crusty bump that won't go away, possibly slowly growing or quickly growing. Sometimes they can look like a wart, and this one on the nose is a good example of that. Now the next picture is really gross. I wanted to show you a picture of squamous cell on the lip just to show how serious it can be. Couldn't find a picture of an early lesion, so here it is. This is bad. This has a very high risk of spreading inside the body, and we do not want anyone to ever let it get to this point. What we can see on the lip more commonly is a little wound that won't heal. Perhaps it bleeds easily, perhaps a little thickness. If you see something like that on your lip that's just not going away, you should pay attention, especially if you have the risk factors for skin cancer that we'll discuss later. So I moved away from that picture not to gross you out too much. This slide illustrates that we can see squamous cell in people with more color to their skin. With having color to your skin, that's limiting the damage you get from the sun. But again, there's other factors that come into skin cancer and can cause it to develop. In darker skinned individuals, squamous cell often develops in places that are protected, like the lower leg, the foot, as well as the hands. Here's a pigmented lesion. This is squamous cell, very early one. Here's one on the leg. Just kind of looks like a crusty wound that won't heal. That's a classic description when someone comes in. I just can't get this to heal. Now moving on to melanoma. Melanoma is one that you're all probably aware of. This is one that has a more significant risk of internal spread resulting in death. And the bad thing with melanoma is that once it spreads, there is not a lot we can do. It doesn't tend to respond well to anything we've got in terms of chemotherapy. So our goal is to catch it early so it doesn't spread. This year there will be approximately 110,000 new melanomas found in this country. About half of those will be thin early melanomas, which are highly curable, and the other half will be thicker melanomas with more of a risk. Now, looking at the stats, invasive melanoma, so again, these are the thicker ones with some risk to them. It's the 6th most common cancer in men and women overall, so it is definitely becoming increasingly common, and it's a very serious threat to our health. In women aged 20 to 29, we're seeing a spike of melanoma. It's become the 2nd most common cancer in women of that age. So age doesn't matter quite so much with melanoma as it does with the other cancers. In general, your lifetime risk of developing an invasive melanoma is 1 in 63. That number is going up every year. About 5 years ago, I would have said 1 in 75. So it's definitely increasing and something we need to be aware of. It can affect anyone. There are certain classic risk factors that we're going to discuss, like the fair skin, the freckling, the sunburns. But melanoma can develop in anybody of any skin color with any history. One of the worst melanomas I ever saw was when I was a resident at University of Chicago. It was a large, nodular, bleeding melanoma on the back of an African-American woman. It had been there for about a year, and she just thought it was a mole until it started bleeding, and then she just thought, it can't be anything. You need to be aware that even if you have a good skin tone, you have a risk of melanoma. Early detection is vital. If you catch melanoma when it's just starting, in situ we call it, very thin, at about 5 years, the survival is close to 100%. As that melanoma grows deeper, as it penetrates the connective tissue, the dermis, the risk of spread internally goes up proportionally. So the deeper it is on the initial biopsy, the higher the risk that it's going to spread. If you have a melanoma greater than 3 millimeters in depth, the survival at 5 years is 55%. So you can see there's a huge difference between just starting and 3 millimeters. And just for a frame of reference, 3 millimeters is probably a little thicker than the thickness of a quarter. So it's not that thick. It's all on a microscopic level. Now the most common sites are the upper back, the lower legs, and the head and neck, but we can see it anywhere. The classic thing is the man with the bleeding mole on his upper back, the woman with the black spot on her leg. But again, it can present anywhere, and it can look different. It can have a variety of presentations that we'll go over. The main environmental risk factor that we know of is ultraviolet light exposure. They're doing studies to figure out, what wavelength is causing the damage, what can we do. And it's not clear yet, but it looks like the intermittent intense exposure that we get increases our risk more than our chronic lifetime exposure. So we're talking about the serious burns of childhood and then the weekend warrior lifestyle. That probably does increase risk of melanoma. Now, not all melanomas are sun-related. We can see other things feeding into increasing the incidence in certain populations, immunosuppression, for example. Additionally, we see it occurring in places that never see the sun. I have had several patients in the last year, I think about 4 now, develop melanoma on the crease of the buttock, a place that definitely never saw the sun. I've seen it on the foot several times, and often the question when we find it in these sites is, how did I get that there? I never got any sun exposure there. We think that when we do get our sun exposure, our intermittent burns, it affects us, of course, locally where we get the burn, but we think it may affect us in some systemic manner that leads to the increased risk. So that's why you do have to pay attention if you see something changing, something weird looking, even in a site you never burned in. Now, early lesions can be subtle or obvious. Obvious ones are black. Jet black can be very concerning. Anything rapidly growing is very concerning. But often the early lesions are just a mottled light brown color, a couple different shades of brown, maybe a hazy border, maybe a funny shape, but it can be very subtle. Sometimes you can see shades of red, white, and blue, and this can be in the early melanomas or the advanced melanomas. You can also see possible crusting or scale and sometimes bleeding. Several of the melanomas I've found that have been early have had a little bit of scale to them. One example I like to use of the importance of watching over your body is I have a patient who is in her 30s and she has gotten sun exposure, but she's careful. Her 6-year-old daughter walked up to her one day and said, "Mom, what's that thing on your arm?" She had a little 3mm black flat spot with a little bit of slight dryness to it. And the 6-year-old picked up that it was different from all the other spots. She comes in, we do the biopsy, and it's the superficial melanoma just starting, completely curable in most cases. So it's a good example that you can have a dramatic presentation of black, and that if you're watching, hopefully you'll pick that up. But an important point is a lot of times the melanomas that we're finding early are not suspected by the patient. Most of the early melanomas that I find are found on routine skin exams where I'm looking closely at all the spots on a person's body. So many times they're a mottled mixed light brown that's just a little funny looking. We do the biopsy and it's an early melanoma. And that's really when we want to catch it because of the cure rate. Now, couple things to guide you, because what I would like you to learn from this is to watch over your own bodies and your family's bodies to look for signs of melanoma. We talk about the ABCDs. You've probably all heard about that before, and I'm going to go through those. At my office, we've added E and F, just because there's a couple good points with E and F. Starting with asymmetry. Melanomas are often asymmetrical. So if you were to draw a line through it, one half might not match the other half. So that could be a sign something's abnormal. That being said, I've seen many melanomas that break that rule and are perfectly symmetrical. Border irregularity is often present, and that can mean a notched, ragged border. It can mean a blurred edge where you can't quite tell the beginning and the end of the lesion. But again, I have seen melanomas come in with a perfectly sharp, round border. Color. Like I was saying, you can see red, blue, white, black. Those colors are concerning, but it can be just mixed shades of brown or even just a dark brown. Diameter is the D of the ABCDs, and classically we say if a mole is greater than 6 millimeters, we have some concerns. The larger moles can be concerning, although we see a lot of larger moles that are perfectly benign. I'll often caution people, if you look at your moles and go, oh, that's smaller than a pencil eraser, that's okay, you're fooling yourself, because a lot of the early melanomas we're finding are very small. The smallest melanoma I've found yet has been a 1 millimeter spot. Very fair-skinned individual. The clue there was a little black dot. But we are finding them that early now, and that is the goal. So diameter greater than 6 millimeters is concerning, but if it's smaller than that, don't rule it out. Now the E and the F. E is evolving. If you see a mole changing or a new spot that you think is a mole changing, especially rapidly, you want to get it checked out. And then F is for funny looking. And the way that I put this is if you look at all your spots and you're kind of looking at your moles, you'll notice that you make certain types of moles. Some of us make brown moles, some of us make pink moles, some of us kind of have 2 populations of moles. All of a sudden you see something and it doesn't look like the rest of it. It's different than all your others. It's kind of funny looking. Pay attention to that. That could be a clue. Now we're going to move into the pictures. I've got a lot of obvious advanced cases I'm going to show you. I want to emphasize that we want to catch it before it becomes like this, if at all possible. Now in this case, this is a serous nodular melanoma. It has the asymmetry we were talking about. It has the irregular kind of notched border. It's got that black color. Additionally, on the right side of the slide, you can see redness and some scaling. So that's a very obvious problem there, definitely a melanoma. Here's one, same sort of look on the bottom half. We see that black nodule, and additionally we can see some red, so you can kind of see that it's been bleeding. Ulceration and bleeding in melanoma is very serious. Thankfully it's not all that common because we're finding it earlier and earlier. Now if you look at the top half, that is also a melanoma. It probably started on the top half and then evolved into this black nodule on the bottom half. So you can't, if you're watching yourself, hopefully you'll see a spot changing. Now looking at the top half, you see that hazy border where you can't quite see where it begins and ends. You see kind of an irregular, jagged border. You see varying shades of brown. So that is a good example of what it can look like early on. Now here's one that is an obvious problem. It's large, it's greater than 6 millimeters. It's on the back of the ear. It's got a nice sharp border, it's uniform, it's round, it's perfectly symmetrical, but the clue is the black color. So some melanomas will break the rules of the ABCDs, bear that in mind, but there's still good rules to kind of guide you as you look yourself over. And here's a melanoma on a very fair-skinned individual. The clue here is how dark it is, as well as its size, its ragged border, and kind of the haziness to it. Here's one with multiple shades of brown, as well as some red and some white, and it's a large lesion, so obviously not a normal mole. Now here's a melanoma that is a little more subtle. You can still see that something's going on. It almost looks like he has a couple different moles and then there's some pink skin in between, but it's all melanoma. Sometimes melanoma won't have color, so the pink areas are the areas lacking color in this case. Here's a slightly more subtle lesion, and this demonstrates the black and the red, the asymmetry, the hazy border, but it also demonstrates the color white that I brought up. It's not normal for a mole to develop an enlarging white spot in it. That's usually a sign of something very serious called regression. The body is attacking this melanoma and killing it off. And you would think that'd be good, but regression on histology is actually associated with a poorer prognosis. So anytime we see white within a melanoma, we do get very concerned. Here's another example where the regression is nearly complete, and in the middle of the lesion it almost looks like normal skin. That's a clue, as well as the black, the hazy border, and the asymmetry of the lesion. Another one with a little bit of white, and then multiple colors, hazy border. The difference between the depth of brown on this and the surrounding skin is a good clue. Now here's one. The only thing that really catches your eye here is that it's very dark compared to the surrounding skin. It does also have slight asymmetry and a slightly hazy border, but a melanoma like this in a darker skinned individual, you might think, oh, that could be a normal mole, so a little more subtle. Here is a more subtle one, and I see ones like this often. On the top we have brown, on the bottom we have red. If you look in the slide to the right, we have another red mole. Some of us do make pink moles. In this case, you have probably a pre-existing pink mole that then developed the melanoma as the brown spot coming out. So if this person is watching themselves, hopefully they see the development of this changing part of the mole. And it brings up an important point. When you develop melanoma, you can develop it in a perfectly normal mole, an abnormal mole, or on normal skin. It can pop up on its own. So if you've had a mole forever, that doesn't mean it's okay. If you see it changing, it's important. A good example of this is recently I had a dark-skinned Italian man come in. His wife made him come in to get a skin check. And he hasn't had very many burns, although he's a beach person. And he had this little tiny mole on the side of his foot. He said, "Doc, that's been there forever. I'm not worried about that. I don't think that's changing." But it just had a slightly funny look, a little dark, the funny border, about 2-3 millimeters in size. And I convinced him to let me biopsy it because it just didn't seem quite right, even though it wasn't obvious. I took it off, and it was a very early melanoma just starting. And the thing he's having difficulty understanding is, why did he get it? He's got dark skin, he doesn't burn, it's a mole that had been there forever. And he's just kind of a good demonstration that melanoma doesn't always follow the rules. You can see it in any skin color, you can see it in a pre-existing mole or a new mole, you can see it on a sun-protected site such as the foot. Now here's a subtle case, and this is more typical of what I'm finding these days. It's just a little bit dark, not dark brown, but a little bit dark. It's got the jagged border, irregular It's asymmetrical, and it's just kind of large, funny looking. I see a lot of lesions that look like this that are even smaller. So you want to look for the subtle stuff in addition to these obvious black bleeding things. Here's an example of a very small melanoma. This is a melanoma on the back of the neck, and it's hard to appreciate from the slide. You know, normal moles can look somewhat like this as well with a darker center. A fried egg mole can be normal, but this is a good example that it can be very small as it starts. Now, this one's kind of gross. This is an ulcerated melanoma. When a melanoma is ulcerated, it's high risk. It's very serious. But another thing this illustrates is if you kind of look at it, you don't really see any brown there. You see a grayish color from the bleeding, but there's no real brown or black or anything like what we saw earlier. Melanomas occasionally lack color. We call them amelanotic melanomas. And they're scary because they are hard to detect, and they're often detected later. So if you ever have something ulcerating or bleeding, we have to think of amelanotic melanoma as well as basal cell, which you'd prefer to have. Now here's an example of a melanoma on the foot. This is on the sole of a foot of a darker skinned individual. It's a good example that you can get it in sun protected sites. Here we have the hazy border, we have the multiple shades of brown. Now this is an interesting one. This is nail melanoma. Darker skinned individuals, especially African Americans, can have pigmented bands in their nail, and that can be normal. If you're a fair skinned person, excuse me, and you ever develop a dark band in your nail, that can actually be a very serious sign that you have a melanoma of the nail matrix. The nail matrix is beneath the fold of skin right before your nail, and that's what's making our nail. And if you get a melanoma there, the color will often show up in the nail that it's making. And so this is an early one, actually. This is a later one. This is one that's been let go. When you first look at it, you might think it's just an abnormal nail, it's fungus or something. The clue is looking at the cuticle, the brown color's bleeding onto the skin, and that's a clue that there may be a nail melanoma present. Now, does anybody see melanoma here? Yeah, the outside of the eye. Ocular melanoma is uncommon. It's less than 1% of the melanomas we see, but it can occur. And you can see it on the iris. And you can literally see it, it's right there. But you can also see it on the retina. We have pigment cells in our retina. And a melanoma developing there is usually detected late unless you're someone getting regular eye screening. It's extremely uncommon to develop eye melanoma. I've had one patient since the beginning of my training, but it's very serious. You want to go to the eye doctor anyway for regular screenings because of cataracts, macular degeneration, and glaucoma. This is another reason to get your eye checks, especially if you have the risk factors that we associate with increased risk of developing melanoma. And the next one, if I recall correctly, is gross. Yes. This is an advanced nail melanoma, and this is in an African American patient. When melanoma occurs in African Americans, it's often detected later and has a higher mortality because of being detected later. This just gives us an example of how bad it can get, and also gives us an example that it can occur in places you don't expect it. When African Americans get melanoma, the most common sites are sites that we call acral sites, so the hands and the feet, the nails. So we have to keep that in mind if anybody with dark skin ever develops a changing lesion. Here's an advanced foot melanoma on a Hispanic male. This has been let go far too long. We hope never to see this. Here's an earlier one. In the center, you can kind of see some crusting, and the patient might have thought it was a wart at first. The clue is the color coming outward, the splotchiness of it, the multiple shades of brown. In the foot melanomas I've found so far, I haven't seen too many serious ones yet, thankfully. I found a lot that are just starting and small. Moles on the foot can be a little funny looking. They can kind of follow your fingerprint lines or footprint lines. But if you ever see something that's very dark or has any of the ABCDs to it, you want to point it out to your dermatologist. Now we're going to move into the risk factors for skin cancer. And most of you probably know these basic risk factors. And this is risk factors for the non-melanoma and the melanoma. Fair skin is a risk factor. So if you're Irish, English, Scandinavian, you definitely have less ability to protect yourself from the UV. You can't make as much tan, so you suffer more damage. But at the same time, you don't have to have fair skin to get skin cancer. Light hair, especially red or light blonde hair, is also an independent risk factor for skin cancer, as are light eyes, blue or green. Additionally, significant sun exposure increases your risk. And we're talking about the multiple blistering burns that a lot of kids will get, but we're also talking about the weekend warrior. You know, you're 35, you're out on your boat, and oops, you forgot your shoulders. If you're getting a lot of those burns, that's definitely a risk factor. It just demonstrates that you don't defend yourself well against UV, and that UV can cause the damage. Additionally, we can see increased skin cancer in people who are outdoors a lot and aren't necessarily burning, but they're getting tan and they're just getting a lot of exposure. We especially see more squamous cell in those individuals, but can also see basal cell and melanoma in them. Family history of skin cancer is very significant. In melanoma, 90% of melanoma cases have no family history. But in people who do have a family history of melanoma, the risk of developing it themselves does go up, and I'll give you some numbers in a moment on that. Additionally, if you have a personal history of skin cancer, it increases your risk of subsequent skin cancers of all types. Now, I've said this several times, and I just want to keep emphasizing it. Not everyone who develops skin cancer has those typical risk factors. So if you've got good genetics, no family history, nice dark skin, you're probably better off than the fair-skinned person next to you, but you still have risk. Now here's some specific numbers for melanoma itself. There are certain things we associate with a greatly increased risk, and anybody fitting into any of this should definitely be followed at least annually by a dermatologist with a head-to-toe check. In a person who's had a previous non-melanoma skin cancer, basal cell or squamous cell, they have 17-fold increased risk of getting melanoma. In a patient with a previous melanoma, 9 to 10-fold risk. Melanoma in a primary relative, that means in your parents, your siblings, or your children, you have an 8-fold risk. If you have melanoma in multiple primary relatives, your risk probably goes up dramatically further, but I don't have numbers on that. Immunosuppression increases the risk of melanoma. And immunosuppression is when you're on medications for transplants or rheumatologic disease, prednisone, that sort of thing, can increase your risk for melanoma, but also does increase your risk for squamous cell in particular. Now the highest risk individual, or well, one of the highest risk individuals would be someone who had a primary relative with melanoma, a personal history of an abnormal mole found on biopsy, and a lot of moles. That person has 35-fold relative risk of developing melanoma. So anybody who fits that definitely needs to get to know the dermatologist well. Now we're going to go into recommendations. And the two things I want to emphasize here is early detection and prevention. The reason we want that early detection for all kinds of skin cancer is because it's associated with outcome. With basal cell or squamous cell, if you catch it early, you're going to have less tissue damage, less scarring and disfigurement from the treatment. If you catch melanoma early, it can save your life. Now, the way I recommend early detection is two things. One is self-skin exams. What that means is you'll look yourself over, and we're talking exposed sites and non-exposed sites, and you look for anything obviously changing. Get to know your moles is what I tell all my patients, so you kind of have a sense of when something looks different. It's best performed with a partner. There have been studies on this, and having a partner, such as a husband and a wife, checking each other, increases the detection of lesions early. For people who have any risk factors whatsoever, I actually tend to recommend self-skin exams monthly if you can do it. In someone who has no risk factors, at least annually, on your birthday, check yourself out. Then comes in the dermatologist. Now, anytime anybody notices anything that seems abnormal in their body, regardless of their risk factors, they should come in and get it checked out to be safe. But additionally, if you have any of the risk factors we've discussed, you should get a baseline screening, and then from there your doctor will tell you how often you need to be seen. Fair-skinned individuals, especially with any family history of skin cancer, moles, abnormal moles, are often seen every 6 months to every year. People with no family history but some risk factors are often seen annually. And then other people with low risk will recommend coming in kind of intermittently every couple of years to get checked out, but continuing the self-skin exams and coming in sooner if they ever notice something changing. Now, prevention. You can't do anything about your genetics. You can't do anything about what we did to ourselves when we were kids and teenagers, but you can make a difference in the damage that you now accumulate as you go through life. And again, that daily incidental light that you get, that really adds up over the years, just like that picture of the woman, the office worker showed you. You can protect yourself against that. I'll give you some tools. And then additionally, you need to protect yourself against the sunburning and the acute, purposeful exposure that we get. First point, never use a tanning salon. It seems that a lot of people are getting into tanning salons again. It's kind of become the popular thing amongst our teens and our young 20s. And it's all related to the sense of well-being. It makes you feel good, and the tan. But the truth is the damage from the tanning booth is probably more damaging than the sun itself, because the UV rays, the ultraviolet rays coming out of that tanning booth, are about up to 15% or 15 times stronger than the sun. So that's really significant. If you think about it, if you're going into a box for 10 minutes 3 times a week for 2 weeks and you get a dark tan, and it usually takes you a week at the beach to get that, you're obviously getting acute damage, and that's going to increase your risk of cancer. Even occasional tanning salon use probably increases risk somewhat. I have a lot of patients who come in, mainly teenagers, who have gone before the prom. And they're like, oh, I just went before the prom. I don't do it regularly. And they think it's okay. And then I have a lot of young women who go before being in a wedding or being a bridesmaid or something like that. And then I get a lot of people who come in to get their base tan before they go to the Bahamas, thinking that they're helping themselves by preventing the sunburns that they would usually get. All of that is damage. You're just getting your damage sooner rather than later. It's safer to practice sun precautions when you go on your vacation, wear high SPF, reapply frequently. Going to the tanning salons is not a good thing. And one example I have is I'm seeing a lot of younger melanoma these days. And I had a 17-year-old girl come in. She's my youngest melanoma so far. And she had brown eyes, lovely darker skin, some freckles, no family history whatsoever. The only thing with her was multiple tanning salon visits before her dances each year in high school. And she developed a pretty serious melanoma on her back, didn't even suspect it. So we are seeing cases like that more and more. They're becoming so much more common, and that's what really worries us. So no tanning salons. Now, protection. It's best to avoid extensive exposure in the peak hours. The peak hours are 10 a.m. to 4 p.m. So you try not to go out then if you can, but if you're going to be at the beach, you're going to be at the pool, what you've got to do is wear sunscreen, and we'll go over the recommendations for that. But additionally, that day-to-day exposure, the incidental damage that we get, makes us look older, gives us more cancer. SPF day-to-day is good, and I'll give you ways to put that on where it's not so gross as sunscreen can be. Additionally, consider hats when you're outside. When you're taking a walk, when you're doing your gardening, a hat with a broad brim that casts shade over your ears, your neck, your face is really going to reduce that incidental exposure that adds up over the years. Sun protective clothing can be helpful, and I'll go over that in a few minutes. Sunglasses are very important for our eyes from the standpoint of the melanomas, which are rare, but more so for macular degeneration and cataracts. Finally, if you just love that tanned look and you can't give up that exposure to get the tan look, try the fake tanners. 10 years ago, you'd look orange if you got it done. But nowadays, I've actually had patients coming in and I'm being fooled by what they're using. And I'll give you some good recommendations. But I've had a few people come in using the Jergens Natural Glow, and I've thought they had a tan and started to say, what are you doing? And it's a fake tanner. So you really can get a natural look from that if that's what you really want, is that tanned look. Now, talking about sunscreens and sunblocks, SPF, that's the number you see on your sunscreen. It's the sun protection factor. That specifically measures protection against the ultraviolet B rays. Those, again, are the rays that cause the burning, the acute damage. So if you have SPF 15 and you put it on the way they tell you to, you will have 15 times your normal protection against burning. But the SPF gives no indication about UVA. We do not have a good scale to tell us what amount of UVA is being protected against. What you need to do now is you need to look at your SPF for your B, and then for your B protection, and then you need to look at the components in your sunscreen. And there are certain sunscreen components that effectively block UVA better than others. The sunscreens we had 10, 20 years ago, they were really good at B, but they really didn't block the A. And we think that's one reason that we're seeing a lot more skin cancer, is that all that A was getting through while people were out there. But now we do have good components that block both. Good UVA blockers include titanium dioxide and zinc oxide. These are physical blockers. When you put them on, they actually stay on top of your skin and do not penetrate the skin. And they literally scatter the UV as it hits your skin so that it never penetrates. And what's nice with them is they do a very good job of blocking both UVA and UVB, but additionally they do not tend to be irritating to the skin because they're not absorbed. In the old days, zinc oxide was thick, white paste, really not pleasant to wear. But now they've got better formulations where it's not so white, it's not so cakey, and I'll give you recommendations on that. Now, other good blockers include avobenzone, Parsol 1789. That is a chemical sunscreen that actually absorbs into the skin and has its effects there. So some people do find the chemical sunscreens to be more irritating because it's getting in the skin. So if you're ever using sunscreen and you get irritated by it, consider looking for one that's more just titanium and zinc. Mexoryl is a newer, broader blocker. It's been available in Europe for many years. It's just been approved in the United States in the last year or so. There aren't very many products with it out there yet. I think there's actually just one, and it's just a SPF 15 facial moisturizer. But look for that in the years to come. As they get SPF 30 and beyond with Mexoryl in it, that's going to be what you want to go for. Your goal is good UVA and UVB. I cannot emphasize that enough. You've got to get something to block the A, something to block the B to reduce the damage overall. Now, sunscreen recommendations. We've always said at least 15, and we used to think 15 was enough. I remember my dermatologist telling me that beyond 15 you don't get much more protection. But we're realizing now that 30 really is better. There was a study where they applied 15 and 30 to a person's skin, and neither site burned. But then they biopsied the skin, and in the 15 they saw what we call sunburn cells. So evidence that there was some damage, even though clinically there was no burn. In the 30 protected skin, they did not see the damage. So right there, that tells me my goal is 30 minimum for everyone. Now the other thing is that in the lab, when they're figuring out the sun protection factor, they're putting on a certain amount. It's a very controlled environment. Studies have shown that in real life, we put on perhaps 1/4 to 1/2 of the recommended amount of sunscreen when we go out. So when you're putting on your SPF 15, if you're putting it on like most people, you're actually getting SPF 3 to 7. So you want SPF 30 minimum. If you're not so good at putting it on thick, go for the 55, and you'll probably get at least 30, and that's really what protects you. Now, what is enough? If you're going to the beach and you're covering your whole body in sunscreen, generally we say 1 to 2 shot glasses worth of the sunscreen. So when you go on a beach vacation, you should be going through your tubes. I actually bring 3 to 5 tubes every time I go for my week vacation in Mexico. So always bring more, always use more than you think you need, and you'll get better protection. Again, aim for the broad spectrum protection. And then when you're trying things, I'm going to give you a lot of recommendations, but try things, see what you like. You want to find something you like, because if you like the way it feels, you're going to use it. If you don't like the way it feels, you're not going to use it, and you need to use something. Now, daily SPF, what I'm talking about here is your incidental damage when you're driving to work, especially April through October. Even on those cloudy days, you're getting significant UVA. I recommend wearing sunscreen in a moisturizer base. It's not greasy. It feels just like moisturizer, but you're getting some protection. And I recommend applying that to your face, your neck, your ears if you wear your hair back or have short hair, and then the V of the chest if you wear a lot of V-necks, the back of the hands, and then the forearms in the summer if you're not wearing long sleeves, because that incidental damage will add up. And I'll give you some good recommendations on products that I find to be nice. Now when you go outdoors for real, and for real to me is anytime April to October, more than 10 to 20 minutes you're going to be out there, bring out the real stuff. You should be wearing your moisturizer every day anyway, so you're protected for those 10 minutes or whatever. But if you're going out to do lawn work, you're going out to take a walk, and you think, oh, I'm only going to be out for 20 minutes, usually you end up being out longer than you expect, and it's better to put the real thing on, the thicker stuff, for better protection. When you are out purposefully, if you're out for more than 2 to 3 hours, you need to reapply your sunscreen. You use up that SPF. And if you don't reapply it and you're out there for 8 hours, you're actually probably doing more harm than good, because you're staying out longer than you would have if you hadn't worn sunscreen. So really put on a thick layer, reapply every 2 to 3 hours, even if you're not sweating or swimming. And if you're fair-skinned, or I'd say this for anybody, but especially if you're fair-skinned, if you're on that beach vacation and you're sitting in the shade, you still need sunscreen. The UV gets through the shade. It reflects off the sand. It reflects off of snow if you're skiing. So you need that UV protection even if you're in the shade, you think you're covered. Now let's talk about specific products, and a lot of these are listed on the handouts for you. These are just ones that I've found through my own personal experience that I've liked them, and various patients have told me they've liked these. I'm not being paid by any of these people, although they should, given how much I recommend them. The moisturizers with SPF, I really like the Aveeno Positively Radiant. It's SPF 30. It's thin, so it doesn't feel greasy at all. It does not tend to clog the pores or cause acne, and it feels really nice. Now, Neutrogena makes one called Healthy Defense Daily Moisturizer. It's a little bit thicker, so if you have drier skin, it's actually nicer to have that thickness. They have 30 and 45, and I do think either is adequate. Now, if you like something a little bit more luxurious, Clinique makes something called Super Defense Moisturizer. It's SPF 25, but it is very nice. You do not need to spend a lot of money on your moisturizer to get what you need from it in terms of moisturizing and sunscreen. There's a lot of products out there. You try and you see what you like, but you don't have to buy expensive to have something nice. And it's kind of nice to buy something inexpensive like Aveeno. If you're putting it on all the sites I'm recommending, you'll go through it kind of quickly. Now, lip protection. We showed that picture of the actinic cheilitis of the lips. We do occasionally see melanoma on the lips as well. So you do want to protect yourself if you can day to day, but certainly when you're out purposefully. There's a lot of balms out there with SPF. Aveeno and Neutrogena have one. They're both 15, I believe. There's one a little bit later on that I have in your handout called Lip Coats by Coolabar.com. That is 45, so that's really good. Now, looking at the sunscreens and sunblocks, the stuff you're bringing out for when you're out for more than 15-20 minutes, Neutrogena Ultra Sheer Dry Touch Sunblock. It's a mouthful, but they're telling you that it's sheer and dry. It doesn't feel so greasy as a lot of our traditional sunscreens. And I recommend this quite often because it really doesn't feel as gross as some of our other sunscreens. They have 3045, and that contains the avobenzone Parsol 1789, which is good. It blocks the UVA as well as the UVB, but again, may be irritating to some people who have sensitive skin because it is a chemical blocker. The broader spectrum, Helioplex, is 5570. It's a little broader spectrum. It's stabilized to last longer, which is nice because if you forget to reapply at 2 to 3 hours and you're more at 4 hours, you're going to be safer with a product like this. I find this to be really pleasing and worth trying. I love Aveeno Continuous Protection Sunblock Lotion. They've got 30, 45, they also have a 55. I myself use the 55. It has a nice scent to it, it's very thin, not greasy at all, and it is broad spectrum. And both of these are oil-free, so they do not tend to make your skin break out. If you like something a little fancier, Clinique, they have this Sun Care Body Cream. I actually love this stuff. I put it on all the time on the weekends in the summer when I'm just going to run errands and be out a little bit as my sunblock on my head and neck and my arms for my protection because it's just pleasant to the touch, smells nice, doesn't make you feel gross at all. It's a little more expensive than the other stuff, so if you're worried about the cost, go for the Neutrogena or the Aveeno for sure. Now if you try all this stuff and you don't like, it's still too greasy, you don't like the way it feels, or you're sweating a lot because you're doing sports and it gets into your eyes, consider some other formulations, such as gels, sprays, and sports screens. These tend to have an alcohol base, so they dry quicker. They don't tend to cause as much stinging when you're sweating, but some people even have problems with this. If you're having a lot of trouble around the eyes, that's a common complaint that I'll get, consider getting a stick sunblock like zinc oxide, and they make these clear these days, and putting it around your eye as your sun protection because that will not tend to run into the eyes. And I put Neutrogena up here. I like Neutrogena for everything, but there's a lot of good brands out there. Now, if you're a high-risk individual, very fair-skinned, and you have a lot of trouble with burning, and you want to go all out, Phthalene makes something called Total Block. Very broad spectrum, very good stuff. And I'll use this sometimes when I go to Mexico, and I find that I never burn through this, and I burn through most things. So this is the best stuff. It's expensive though, and you can only get it through coolabar.com. But if you want to do everything you can do and you have a lot of trouble, it's worth trying for your trips. And then there's the lip coats that I was telling you about. Now kids, there's lots of good stuff for kids out there. In fact, Aveeno makes a product line called Aveeno Baby, and that stuff is really good. Additionally, there's something called Blue Lizard. Also, you get it through coolabar.com. I like Blue Lizard because it's got a fun name, so kids like that. And the bottle is actually an educational tool. When you take the bottle and you have it indoors, it's going to be white to very light blue. When you take it out into the sun, it turns bright blue. They actually have put something in the bottle so that when UV is detected, it changes colors. And so you can teach your child that the sun makes it bright blue. There's lots of UV. Then you take the child into the shade, like under an umbrella, and they'll see that that blue goes down, but the blue is still there. So it teaches that UV penetrates shade and that you need to be covered both in sun and in shade. So it's really fun. And I've used this myself, and it's very nice. I like it. Sun protective clothing. Everybody should consider broad-brimmed hats when they're outdoors in general, just to shade their face, in addition to their sunscreen. That will reduce your damage more. People who are more concerned, have more risk factors, especially want to do that. UV protective clothing. UVA can penetrate clothing like we've discussed. Your darker colors, your tighter weaves give you more protection than your airy white shirt. So consider that. But additionally, there are actually UV protective clothing lines out there. Coolabar.com has a good line. There's a bunch of other ones out there. This is especially good for high-risk individuals who really are nervous about being out in the sun. So I have several melanoma patients who don't want to give up their gardening, and so they wear the hat, they wear the sunscreen, and then they get the sun protecting clothing, and they feel much more comfortable with that. It's something to consider, but I think the most important thing to take from this is the sunscreen. Apply high SPF, reapply frequently. Now, artificial tanners. I did not put this on your sheet, unfortunately. It's the only safe tan because it's a fake tan. Tanning salons are really bad. Real tans are bad. Fake tan looks good, can fool your dermatologist if you do it right. And you'll get that look that you want, so it won't be so hard to avoid the sun exposure. Now, most of these do not offer any sun protection. A fake tan is literally color deposited in the top layer of our skin, so there's no protection from that tan itself. But some of the products do have SPF in them. So what I'm liking these days is these gradual tanners, like the Jergens Natural Glow and the Dove product. You put those on daily on your arms and legs or wherever you want to. Has some sunscreen in it, so you're getting protection from your incidental damage, and it gradually builds up the color to the degree that you want, and then you keep it there. And I honestly have been fooled a few times by people using the Jergens, so really consider that if you like the tanned look. L'Oreal also makes a nice one. So the main points from all this information that I've bombarded you with are these. Sun exposure through purposeful and incidental exposure leads to increased aging and skin cancers. Daily protection of your skin and your eyes decreases risk overall. The goal is to prevent your precancers and skin cancers as much as you can. Self-skin exams are needed, and our goal here is early detection. Again, because the non-melanoma skin cancers can be very destructive, the melanomas can be deadly. And then finally, regular dermatologic exams are important, especially for people with risk factors, but anybody who has no risk factors but finds something on their skin should definitely come in, and a baseline screening exam is a good idea for most people. Okay? Any questions? All right, thank you very much.